अरे सर इतना क्यों, इतना क्यों? तो এত দূরে আছে, এইদিকে এইদিকে 1 মিনিটে আছে। অ্যাটেন্ডেন্স দিতে হবে, না না অ্যাটেন্ডেন্স দিতে হবে, এদিকে আসুন। দেখো আমাকে দেখি। I am what you think, I am front of the camera, no, I am mechanical person, mechanical things ready করা আমি আবার আমার কাজ আছে। ঠিক আছে हमने तो সমস্যাটা পেশেন্টটা ইউএসএ মানে বললে ডিটেইলস দিয়ে দাও। এটা বল দিই আমি वो शर्ट के अंदर वही है, वो शर्ट की बुक नहीं है, हाँ देखा ना। What is the name of the patient? Sulata Mukherjee. Okay. Sulata Mukherjee. Hello. আমি আজকে আপনি ক্যাট লাগবে। হ্যাঁ বলুন স্যার, আমি অন কলে আছি, আমি আর ডক্টর প্রদীপ স্যার।
Dr. Hajra will join within few minutes.
ফোন করে জিজ্ঞেস করে ফোন করতে পারবে না তখন স্যার কিন্তু ফোনে কথা বলে না ওখানে ফোন একবার আমাকে নামটা বলুন, আমি তিনটে বলছি আপনাকে পেশেন্টকে কল করে দিতে পারি, একটু জাস্ট নামটা আমাকে বলুন। হ্যাঁ স্যার তিনি আপনি তাহলে ডক্টর হরিকে একবার কল করতে পারেন, ডক্টর হরি বা ডক্টর মানিক कितना बोल रहा था, मैं तो मैसेज कर दिया, इस डिटेल्स दे दिया है मांगते हैं। अच्छा ठीक है सर, तो कल तक फोन में बात करें।
I will request everybody to please mute except the operator.
Hi, I've joined.
Now Dr. Hajra is also joined. So now we can start this. Just I would request DD production to make it live and confirm us when it is live. So Dr. Hajra sir, now it is live. So we have all the expert panelists are already joined, and Dr. Bhattacharya is also there in the lab, so you can see the lab photograph. So you can just start proceeding, sir. So just for your information, sir, we have Dr. Debashish Ghosh, Dr. J.K. Padhi, Dr. Nishant Tripathi, sir, Dr. Professor Shoidur Rahman Khan from Bangladesh, already joined, along with Dr. Binayak Deb. So over to you, sir. Now it is live.
Some doctors have joined. I could gather the name of Dr. Hajra, Dr. Ghosh, Dr. Padhi, and Dr. Dev. Is that right? 2.5 by 15. Can you show the slides? So let us show them the slides because we are already a bit late. Show the slides, please. So show the first slide. This is the last one. Show the first slide. Next slide. So our patient is a 61-year-old male patient who is an ex-smoker, hypertensive. He complained of shortness of breath for 2 months. And when he came in, he was in sinus rhythm, blood pressure 140/90. And you can see the blood reports there, creatinine 1.16, and LDL of 184, RBS 138. He is a diet controlled diabetic. Next slide. And this is the ECG. You can say that there are some ST changes in the lateral precordial leads, but apart from that, and also in one AVL, but not much else. And next slide. And you can see on echo, there was concentric LVH, as you would expect in a patient with hypertension, mild anterior wall hypokinesis, EF 60%, and not much else. And next slide. And this is the CT angio. You can see that there is a LAD D1 bifurcation, LAD D2, sorry, bifurcation stenosis, and it is like 011. And where is the balloon? Balloon ta dekhao. There we are. Okay. So what we are looking at is a LAD D2 stenosis, and it is quite tight, as you can see from the CT angio. So now we are going to show you the angio pictures. So can we go live on the screen? Go live on the screen. Stop the slides. So show from the first slide. This is the first. This is the first angio that we took. Now go to. And this is the areocranial view, and here you can see it best. So you can see very tight LAD stenosis and a very tight diagonal stenosis. And next one. So we have done some work. So we were trying to wire the LAD, and you can see this is a SI Sion blue wire. It wouldn't go. So we took a little bit of balloon support, went into the diagonal, and then we directed it into the LAD. So, and next one. So there we are. We did a little dilatation of the LAD, and next one. Next one. And then we wired the diagonal as well. So that is the diagonal. So there again, the diagonal is also very tight. You can see the wire buckling. This is a saw, and there. So 2 wires there. Next one. So this is a big diagonal with a lot of branches. Initially, the diagonal looked like 2.5, but later we realized it's a bigger vessel. So we dilated the diagonal, and then we took the IVUS catheter down. So I'll show you the IVUS images now. So show us the diagonal image. It's a dilatation while we are talking. So show them the first diagonal run. So 10 balloon, na? 10, 12. Deflate. 3 child. Oh, अच्छा, right. Deflate. 3 gallon आता है. And ekanaba. So if you can see the diagonal run on your screens there, you can see that it is not a small vessel. Distally it is at least 3. And so this is a 011 Medina LAD D2 stenosis. The diagonal is 3. It is quite heavily diseased in the osteoproximal segment, and we have to do something about it. We cannot go for a provisional because quite a long segment of disease. So we have decided to do a DK crash. So I'm going to show you. Can we go on to the just show them the LAD as well, the LAD run. So that is the LAD run. So we are taking from where our supposed distal landing zone is going to be, and we are, as you can see, the LAD is not surprisingly, a bigger vessel than the diagonal, and the proximal LED is quite large. It's almost 4.5. So we are here. We are doing some, as we are talking, we are showing you the pictures. We are doing some work on the diagonal artery leaflet, because we are going to stent the diagonal first. So any comments or any suggestions, any discussions anyone wants to make, or otherwise we'll just go ahead with our case. Yeah. You can go live on the screen.
Anyone from the panel can ask any question to Dr. Bhattacharya for alternative strategy. Like as I said, DK cross is a good option, but this can be done in a different ways, in a different setting, different hospital, different operator. But imaging is of utmost importance. And if anybody wants to make a comment here, please go ahead, Dr. Dev or Dr. Adi.
Go up. 10, 12, 13,
14. Dr. Hajra, I'm Dr. Khan.
18, 20.
Yeah, go ahead, sir. Go ahead. Go ahead.
Yeah, nice to see you. Dr. Devdutt, just in this part of the planet, always we usually think of the almost of the similar diameter of the both side branches, but actually we always like doing the decay crush. But here also maybe the alternate way to go for it, I mean, culotte maybe possible, because it's a angle and everything is favorable to that one.
Okay. Okay. Any other comments? So, এইখানটা আরেকটু করতে হবে না আমাদের আরেও cranial দেখাও তো yes thank you Dr. Khan
yeah
culotte is a technique that I don't use a lot and as you would agree that in these cases you should go for the technique that you are comfortable with.
Mm-hmm. That's true. That's also true, like PVC main.
And
can we see the circumflex, because why circumflex is important here? If you go by SNH criteria, South Korean criteria, you have a large diagonal, first diagonal, then you have a second diagonal, so you get one plus point, advantageous point, because of two diagonals. Maybe the first diagonal is bigger caliber, supplying more than 10% of the area. Now, if you have a branch from the circumflex, like OM1, supplying the apex, a large OM, you can play with this diagonal. If it closes, nothing is going to happen because of the supply zone of large first diagonal and SHH criteria will be in favor of doing a simple provisional stenting given. Now, if you do not have any large OM from the circumflex, if you have two large diagonals, it is mandatory to keep this artery flowing. And you can have a decay cross or culotte-like strategy or tap strategy. So we want to have a view of the circumflex, the OM, the territory it supplies.
Yeah, I'll show you the circumflex, but I don't agree that if the circumflex is large, it doesn't matter if this diagonal closes down. Show them the circumflex. Come to RO caudal. That is a very crazy thing to say, that if this diagonal goes down, nothing will happen. I'll show you the mark.
No. This is by SNH criteria. The size,
I don't know.
UPT, height. There are 4 criteria, 4 points you get. If you have a large
so
wave,
you have seen it. You have seen the
apex. Yeah, there is not a big OM1 reaching up to the apex. So this diagonal is important.
Yeah. So now we are agreed. Thank you. So what we have done until now is we have dilated the LAD and we have dilated the D2, and what we are going to do is we are going to stent the D2. So let's have 3/38. So you looked at the IVUS image, Dr. Hajra. So
Yes,
what
yes.
size stent do you suggest?
I think if you are
Diameter.
doing HDI verse, I would take 2.75 for the diagonal and 3.5 for the LED. So you can make 2.75, 3.5. It's not an issue. But I'll go by 2.75 in the distal reference diameter for the large diagonal.
Okay, 2.75. We will go with you.
So how long you are taking that one?
Sorry, it's a.
How
We'll take
long it is?
the length.
2.75. How much?
2.75 by 38. That was what the length was that we measured. So we'll try to keep as little bit of that stent in the LED as possible. So what we will do is it a diagonal LED. Now give us the diagonal stent first. So we'll put the stent in the diagonal. Yeah. Okay. And we'll see. তুমি আমাদের cranial ভিউটা দাও না। আর আমাদের একটা 3.5 এর নিয়োগ বেলুন দেবে। Show us distal wires, please. Okay. Okay.
Alternate thing, Dr. Hajra, just if as there is a CT angio here, so you can also measure the length of the side branch, like 72 or near about 72 millimeter. So we can predict that it is supplying the 10% or more than 10% of the myocardium.
Yeah, I think that is SNH criteria. The study tells us,
Yep.
as you are mentioning, it has to be more than 72 millimeter or more than 2.5 millimeter.
Yeah.
Then you get 1 point to have at least 10% of the myocardium compromise. So diagonal may look large, but if it is less than 2.5, and if you have a height means you have a large diagonal coming before that second diagonal, your territory may be less than 10%. So CT scan will tell you the size.
এটা একটু এগিয়ে দাও।
Territory size will be done by myocardial perfusion study. Myocardial perfusion study tells you whether 10% or 20% of the myocardium.
Epicranial. Yeah, I think if it is a 3 millimeter vessel and it has a lot of branches like this diagonal does, that is a fair indicator of the fact that it is supplying a lot of myocardium. You can see it has a lot of branches. But yes, I mean the criteria that Dr. Hajra is saying.
Yeah, it looks very, very large, long diameter diagonal. So in this case, this diagonal is important. The zone between the LED and circumference is almost a ball zone.
Okay, what I'm going to do is I'm going to just push this stent down a little bit, and we are going to take our balloon, which we are going to place in a strategic location so that we can crush the diagonal stent. So we are going to take a 3.5 balloon. Okay. এইটাতে diagonal ওয়্যারটাতে তুমি এটা পড়িয়ে রাখো। ওকে, আর এই ওয়্যারটা ধরো। So I thought that the diagonal would be 2.5, but as it is that sometimes after you have dilated it a little bit and then you do intravascular imaging, you realize it is a much bigger vessel. So I agree with Dr. Hajra that wherever possible, you should try not to do a 2-stent strategy. That is the broad philosophy. I agree with that. But in this case, we were hoping that we would be able to do this with 1 stent and keep it simple. But in this case, it was not to be. So, cranial, please.
I think I agree with you, because this diagonal almost reaching up to the apex is a kind of parallel LED. So this diagonal important and there is no OM. So these are keeping this artery open and patent for longer period of time is actually reduce the need for repeat revasculations. So it may not get into mortality benefit, but repeat revasculations of the diagonal branch with angina will be an issue in the future if you do not treat this.
Yeah. We are at a
Hajra, now the Antonio Colombo is just pushing us towards the DCB or DEB. So that also another option we can use here.
That's the right idea, Dr. Khan.
Yep.
So you have mentioned that going DB in the diagonal, if you have a long stent requirement for the diagonal, it is basically complex bifurcation as far as the complex bifurcation definition. The bifurcations, it is more than 20 millimeter by definition to study. And in this complex bifurcation, we really want to reduce the metal burden as Antonio Colombo. And in our hospital also, we do prefer a DB in the diagonal. The only problem is if you have a DB and dissection of large segment, the chance of dissection is increased if you have long segment disease, if you have large vessel disease, and if it is like a parallel LAD, you will end up with two drugs after you have the DB and a drug-eluting stent. So
Prakash,
that is your call.
Prakash, just tell us what your comment is about the positioning of the diagonal stent.
Yeah.
So do you think I should implant it here or pull it up a little bit?
No, it looks perfect.
Huh?
It looks okay here.
Can you take a aerocaudal view or some
two views
to see the angle?
Aerocaudal now? We want to make sure we are not missing the ostium.
No,
that's it. Because the origin of the diagonal is a bit ambiguous, a bit different.
Better to R on the LAD side rather than R on the diagonal side, because the osteo always a child of LAD is a territory of LAD rather than LAD. A diagonal so diagonal ostium is territory of LAD always.
Maybe I'll have pulled it too much, no?
Like, it's around about Dr. Dev, it's around 3 millimeter now, so it's okay. 3 millimeter in the LAD, so it's okay.
I think we'll implant it here. So go up. 4, 6. 6 cranial though. Careful, don't crash our cath lab. Okay, careful. Yeah. Okay. Now we are at 7 atmospheres, right? 6 atmospheres. So we first inflation, first inflation, we always give a low inflation and to make sure that the distal edge is okay. So we will deflate here and we'll take a picture. And if we are happy, then I'll just pull the balloon back and give another high pressure dilatation. Okay, I think the distal is,
it's very interesting that when I see a live case from India, always I see that all the odd numbers to inflate or deflate, like 7 atmosphere. In our country, it's always the even number.
It's a diagonal. Okay, go up here. 10, 11. Deflate. So,
are you going to optimize diagonal stent first, then you remove your wire and balloon, because you are going for higher pressure proximally pulling the balloon? But even then, it needs some kind of extra beat of nudging the stent by using at least the 2.75 non-compliant balloon, so that the mesh the diagonal is.
এখন কিছু করো না, আমরা ডায়াগোনালটা পুল করছি, তাই তো? Yes, we are taking it out.
Please,
what I
please
have to
keep the balloon,
optimize.
keep the balloon in LED, keep the balloon in LED, and also digital optimization of the side branch is very important.
Yeah. So optimize that diagonal first, then you remove. So this is the extra step you are taking in the decay cross. If you are using more than 20 millimeters stand in the side branch,
Okay.
so this is
Crush
one extra
karo.
step.
LED ta crush karo. Crush the LED. Crush the diagonal stand. Okay. 10, 12, 13, 14, 15, 16. Deflect.
Now the problem is if you fail to cross that stent you have not imaged in the diagonal, stent may be underexpanded. That may cause the
Okay. Sorry. 8
immediate long-term
we
risk.
will be able to do it.
Okay.
We are quite happy about this. Okay. So just give us a moment. Let us sort our wires out.
Any comment from Dr. Padi or Dr. Devashish Ghosh?
Yeah, Dr. Devashish Ghosh is absolutely quiet.
No, I'm quiet. I'm just sort of carefully following you. I think it's always better to understand and follow the case and then make a comment. I would agree. Devdatta, you could have the distal diagonal. Maybe you could have optimized distal diagonal. It'll make your life easy if you take a smaller balloon and just do the distal diagonal optimization. So
We'll do the diagonal optimization later.
Late. Yeah, fine.
Okay.
I think it's absolutely a strategy which you can follow. I don't have any argument against it. But maybe it would have been simpler because the balloon was there and the wire was there.
balloon there. Contact inflation. 8, 9, 10.
Dr. Padi, are you there? You can make some comment.
Yeah, I'm just watching and I appreciate your comments that because the side diagonal you have put more than 20 minutes. It's definitely difficult decay to do and you have to optimize the stent in the diagonal. Closing may be difficult. Let us see how he is doing. And
so he's the expert. He can do it later. But for the beginners, I think optimize
12,
the diagonal
13, 14.
is of utmost importance before you take out and cross this diagonal stain. And Dr. Ghosh, Padi, and myself was suggesting, and Dr. Khan also agree with me, that perhaps it is much easier to optimize the diagonal, but it can be done later on also.
Diagonal optimization, what do you mean by that? I mean, which part of the diagonal you're telling?
I mean, if you have put a stent in the LED, suppose 2.75, 28 millimeter, we would have optimized the LED stent. Similarly, if you're putting,
we did optimize it. You missed the step.
No, you have optimized with the stent balloon. What we are saying, you have to optimize with the non-compliant balloon. High pressure.
Okay. No, I never do that.
Okay.
No. We'll do it later. Let us have a wire, please. We have to recross now. So let's see whether we can recross or not. If we can't, then that is a problem. But usually we are able to recross.
Yeah, in complex bifurcation is always, Dr. Ghosh will agree with me, and you want to have your plan to image the diagonal also. If you have a long stent in the diagonal, large parallel diagonal, you also want to have imaging of the diagonal after optimizing in the first place, in the first step.
Eleo caudal esho. Okay, so let's look at that. How are we with time? How are we doing with time? Are we okay with time?
You are okay with time.
Okay. Okay, let's go to that cranial view maybe, or epicranial. Let's see whether we can recross.
Devdatta, can you just define the wires you are using while
both are Sion blue wires. So if this doesn't cross, then I will take an intermediate wire. So there we are. Okay. Let's have a na 3 na. আমাদের একটা 1.5 এর balloon আগে দাও. So it is usually not too much of a problem. এটার LED ওয়্যারে একটা টর্কার দাও আর আমাকে 1.5 এর বেলুন দাও So we are going to just open up the struts a little bit, and then we will do a kissing balloon dilatation.
Dr. Devdatto, is it in the proximal strut or in the distal?
I don't care really. I will I will dilate it. If it doesn't go, if the balloon doesn't
Yeah.
go, I will do a OCT and
Okay.
find out where the cross is.
Mhm.
Yeah, it's very difficult to pinpoint the distal and proximal cross without OCT, and it is all a guesswork. Like if you have a less than 70 degree angle of the diagonal versus LAD, it can cross proximal easily. But if it is more than 90 degree, it is very, very difficult to cross proximally. So it's an
Yeah.
easy angle you can cross proximally.
And also, Dr. Hazra, I can tell that if it is in the left main, then it is easy. But if it's in the non-left main, it is really hard.
Yeah.
So why people say that left main bifurcation is a very dangerous thing? I don't think so. I think non-left main bifurcation two-step technique is harder than the left main bifurcation two-step technique.
আমাকে একটা New York balloon ready রাখো, huh? If this doesn't go, you will see OCT coming. We are yeah, having a little problem.
What balloon is that, Devdatto?
1.5, but this balloon is a once used balloon. So what I will do is I'll take a new balloon and I'll see.
I think that would be wise. You know, a single marker knee of balloon would be.
Can you hold this? Yeah. Yeah. Usually, the thing about DK crush is that you need at least 5 new balloons to do it smoothly. Otherwise, you can struggle a little bit.
What size of guiding catheter, Dr. Bhattacharya, you are using?
It's a 7 French.
Oh, good. So that's a very important step, because in Indian scenario, because of cost constraint, we have to use sometimes the FOC free of cost.
Sheet
To negotiate French.
The sheet. Yeah, 7 French we are doing radially, but we are used a slender sheath and we are using a 7 French catheter.
So it's not behaving like an Indian artery, at least for that one. With the 7 French, is accommodating in the radial artery.
He's a big man with a very good sized wrist.
Yep. So, because I rarely find this 7 French catheter in radial artery in my center.
If your patient has a very wide wrist, then it accommodates it quite easily. Okay, দেখি এদিকে দাও, আমার দিকে তাকাও। কোন ওয়্যারটা দিয়েছো দেখি, তুমি ধরেছো ওয়্যার? ওকে। In ladies, it is a little more difficult. That I agree, but but in men, if you are a
for live cases, I usually choose also the configuration of the patient.
Yeah.
so that he can get everything easy.
Yeah.
Do you have a wire wrap type of scenario there?
No, I think it's more likely that I have crossed through a unfavorable stent strut, which is causing me the problem.
Then you have to crush it again.
Okay, we'll do OCT. Chalo, let's do OCT. I think we'll do OCT and we'll analyze. Okay. Chalo, let's have the OCT catheter. I think it has gone through a stent strut which is not favorable. Maybe a crowded segment of it has gone through. Sometimes it happens like that, and best way to find out is doing an OCT. So we'll do that for you. Ready, Shovik? So just calibrating our catheter here.
Sometimes, Devdotto, it might be, I know OCT is probably the best way. I don't doubt that at all. Sometimes trying to get just get it another wire, because this wire has now a marker. The side branch has a marker of the point of entry. If you try another wire and try to enter it from a different place, again, much more guesswork than an OCT. OCT is much more definitive. But if you don't have OCT on the table, that is something you might consider.
Yeah, already that part has been missed already. So now you can go again with that one. Yeah, but that's a good thing, because I usually do in that way sometimes whenever the struct is the concern.
Yeah, in DK class, though they have mentioned proximal crossing is one of the steps to be followed. But if we have a link at the proximal crossing, as in this case, as Dr. Bhattacharya has rightly mentioned, it was not a nice crossing, and presume that it is a proximal crossing, and it is a link-rich crossing, then you have to recross. I mean, one OCT we can understand whether it is a link-rich proximal crossing, link-free proximal crossing. If it is link-free proximal crossing, then it's okay.
देखिए আমার ওয়ার্ডটা ফিক্স করো।
Dr. Ghosh, do you have any choice of stent? This is a clear-cut diabetic bifurcations, complex bifurcations, a long stent in the diagonal, long stent in the short stent in the LED, long stent in the diagonal. You have a choice of stent?
I think any of those modern stents will be all right, because I think the bleeding, high bleeding risk issue is not there in this patient, as far as I could understand. So any good modern stent, I wouldn't be too fussed about what stent I'm using, provided it is one of the more modern stents. That's all. I wouldn't be too fussed about it.
I agree with you. Dr. Khan, you have any choice of the stent in complex?
No, just the newer generation stents I usually prefer, because those stents, as the strut thickness is gradually getting down for this sort of new generation stents, and also you know that expansibility is very much important for two stent techniques, because you don't know how much you will have to expand.
Okay, would you go for FFR in the diagonal in the DK class for effective DK class outcome, or you just go by the anatomic thing and to finish your case?
Just not to complicate that much actually, because you know that if you have DFR option is there, then it's just you can take that one. But for FFR, you know, it's a hectic thing. Just go take hyperemia, go blah blah things after doing such a long procedure with the two stent techniques with DK crash. Actually, you can tell theoretically, but not practically.
What about QFR? What about QFR?
Bathroom peche? Hey, give him a
phone. The QFR is there. QFR is near the newer one, but we don't have that option now. Whenever it will have, we will have that one. That's a beautiful thing.
Test.
But
QFR sometimes. Yeah, that's what a question.
Yeah.
Okay.
Yeah, I think.
Can you see the screen for the OCT?
Yes.
Okay, we are ready for the OCT. I'll just.
Dr. Ghosh, go ahead. Dr. Ghosh, go ahead.
Okay.
No, I was just saying that I'm not too fussed about after you've done a good work and the image looks all right. 54. If you look, even when we have the provisional stenting, most of the osteums which look a little bad, if you do an FFR, actually they are all right, because the opening of the ostium is sometimes elliptical and not a straight round. And so what doesn't look too well on the angiographic image, actually the flow and the physiology is pretty all right, because it's an oval rather than a round. So most of the studies have shown that even when you have a provisional stenting and the ostium does not look very well on the angio, if you do an FFR, most of the studies have shown that the FFR remains fine.
Okay, Dr. Padi, what will be the best endpoints, clinical, I mean, angiographic endpoint or procedural endpoints in this patient? Angiographic TIMI3 flow, good MLA more than 4 millimeter square or less than 4 millimeter square, in reference to the distal vessel diameter, the diagonal, and
Chalo.
diameter,
Show us.
paper, or all of them, or none of them.
Okay. We have this image coming up, so you can analyze it for us.
Yeah. So we can see some stents protruding into the LED, and this is run from. We missed it.
This is run from LED.
Okay. So can you see? So it is a distal crossing. Dr. Khan, your comment on the OCT?
We can do a.
Yeah, it's a far distal. It's like a far east. So you have to pull the wire and go proximally actually.
Or you can keep this wire,
and take another wire. Take another wire.
So you know the proximity.
Yep.
That will be lighthouse for the distality. So you have to cross proximally with another wire. So you know there is few gaps left between the first wire and the second wire without doing another OCT to confirm it.
If you remember, Prakash, that was exactly what I was alluding to. That even before the OCT, can we try another wire, try to go more proximally?
That intermediate wire.
Yes, I think you are made a brilliant point.
Absolutely spot on, Dr. Ghosh.
Yeah.
That is what we are going to do.
Brilliant
point.
But
this is to demonstrate that how OCT shows you where you are. And
yeah. OCT is always a Cadillac. Okay, fine.
OCT is like Dr. Devdatta, you are inside the artery. You yourself inside the artery. You are seeing everything so distinct.
This is something that OCT does that IVUS cannot do. And that is to show you exactly where you have crossed it.
It's so pristine picture.
And you can see it has crossed through a crowded part of that ostium, where what the Dr. Hajra was saying, that it is just crowded up there. And this is one of my indications for doing an OCT. If I find this
there is also one observation, Dr. Bhattacharya, for my friends. There's a mega crash. I mean, there are a lot of stent and correctly show is not a deviations from the standard of care, that you have to have at least 2-3 starts in the LED to have effective decay crash, rather than just be at the ostium like nanocrash. So nanocrash, you have very few metal, but in decay crash, you have at least 2 millimeter of stent in the LED, and nicely demonstrated that the first step he has taken, pulling the stent little bit in the LED, was a perfect step to be taken for decay crash. Dr. Padhi, why you are so silent? Unmute yourself.
I am absolutely agree with you, sir, that it should be at least 2 to 3 millimeter inside the LED for decay crash.
Dr. Hajra, how much you are doing the nano crash now in Kolkata?
Look, initially thought we'll do each and every bifurcation steps and type of bifurcation in one lab. Now we have decided, I have told so yesterday, that one center, one technique. So AMR at Hakuria for decay crash, and if I do same thing in Salt Lake, I'll do Culotte, so that everybody knows what are the steps sister nursing technician. So we have decided to restrict ourselves, either professional or decay crash or nano crash. Very, very rarely.
While doing nano crash, you are using the Shivanand's steps or Morris's step? Which one?
Okay, Morris, Shivananda, both are okay, but sometimes we keep an IVUS catheter, like eye of the IVUS in the, for example, as I mentioned in the LED left.
So as you can see, we have recrossed. What do you want us to do? Do you want another OCT or?
You take the balloon now, Dr. Devdatta, whether it crosses now or not, because that's
the balloon
challenge
now.
Yeah, that's the challenge.
Yeah, all right. You don't want to watch OCT, I'll take the balloon. You don't want that fun. 1.5. Okay. We are also a little pressed for time, so I'll take the balloon. It হচ্ছে আমার diagonal wire. Get it? 1.5 এর বেলুনটা দাও, এটা নিউ ইয়র্ক বেলুন নিলাম। All right, let's see. So Dr. Ghosh, I have done exactly as you have suggested, and we'll see. I hope we have not gone in through that same small strut, despite having kept the wire there. And I hope this time it crosses. So,
Any comment from Dr. Mandar Shah from Jamshedpur? I think.
Dr. Mandar Shah is here.
Yeah, I'm just closely watching all the steps.
No, you have to speak. This is time to speak, as if you are doing the case.
Right.
I
right.
think
Okay.
I might have
Till-
gone in
till
through that
his-
same
till his-
strut, huh? No, I think I'll just take
I'm
this
trying
out.
to switch on my video. It is giving me an error saying that access denied. I don't know why that is.
You can speak so that we can have a conversation.
Fine. So till his crossing across into the diagonal with balloon, one query.
Yeah, go ahead.
The
Go ahead.
balloon won't cross, so I think I might have gone in through that same strut again. I'll try to take this out and try to recross again. The balloon won't cross easily. এটাতে টর্কটা দাও তো।
Or you can give a crush, another crush of 3.5 at higher pressure at the LED, so that there's a redistribution of the link.
That we can also try. Yeah.
There is actually some crowding of.
You have a 1.255 in your lab.
The ostium.
Yeah.
Dr. Devdatto, do you have a 1.255? You can take that one also.
I think I've deformed this wire now a little bit. Let me see. Let me just try for a bit.
Sometimes what we have found is if we get stuck up at this tip where we are not able to cross across with the balloon, then we take this 1.5 balloon or 1.25 balloon, whatever, till wherever it goes and just inflate it over there. It creates just enough of space, and then after you deflate it and then you try to cross, it will cross. This is something that has happened.
That is called nose diving. If you just put your nose out at the start and inflate it, sometimes your nose can go in before your mouth or the head goes in. But only problem is if you fail, you lose one balloon.
Yes, that's right.
True.
Okay.
Since he has a OCT with him.
Yeah, he has shown the OCT, Dr. Mandar.
Yeah. I saw that.
Can I have that
I saw that
diagonal wire, cyan blue wire again?
Or you can take a more steerable wire like a Gaia 2, where you can understand the movement of the tip to be proximally or distally. This iron wire is not steerable. So you have to have a steerable wire. Or you take a microcatheter, double lumen microcatheter. If you have a double lumen microcatheter, you know that the second marker is actually averting at the middle or the distal or to the proximal. So these are again guesswork, but it can help. So dilatation of the LED balloon, different wires, double lumen microcatheter. Yeah.
Yes, I think these are all good suggestions. Let me just try once more with this cyan blue wire and see. If it doesn't, then I will crush that stent a little bit more and try. Okay. All right, that's the first diagonal. That's the second diagonal. Epicranial. Okay, I don't want to see that. Maybe this is a little better this time, no?
Yeah, looks better.
Take a look at that. Yeah, probably this is a better cross.
Yeah, it's
1.25 balloon though. I am a little more optimistic about this cross. Show us the previous picture and see whether we can distinguish between the two crosses. এটা তো এইবারের আগেরটা দেখো 1.25 এর বেলুন দাও হ্যাঁ এর পরে দেখাতে হবে 1.5 দিচ্ছ ঠিক আছে 1.5 ই দাও চলে যাবে মনে হচ্ছে at least we have something to discuss because I am having difficulty and I have so many experts to guide me. Okay, LED টা আরেকটু পাঠিয়ে দেওয়া যাক হ্যাঁ let's see what happens this time.
And sometimes when you have a compromised LED for long procedure, you can go for a half decay cross. The half decay cross is like you just put a stent in the LED and forget the first creasing and finish it.
Go up. Now we have crossed. Just give us a moment. Go up.
You are a purist. I mean, I'm not a purist sometimes.
10,
when
12,
I see
13, 14, 15,
low
16,
flow dissections,
18.
just put a stent in the LED and
yes. If you think that the main vessel is under threat, you want to preserve the main vessel.
Yep.
Yeah, I agree with that. Yes, but here we have crossed, so I think it will be smoother now.
Yeah.
So eta dhoro. Okay. Unfortunately, the last time we crossed that same crowded part, but this time we managed to cross it at a right part. And what we'll do now is we'll do a to make matters simple. আমাকে 3 এর বেলুনটা দাও. We'll do a sequential balloon dilatation. So we'll first dilate the diagonal, then we'll dilate the LED, and then we will stent the LED, and then we will, in the end, we will do a proper kissing. So we'll just modify the procedure as because I agree with Prakash that we should not leave that LED unprotected for a very long period of time. So I hope you agree with that, Prakash.
Yes.
Devdotto, just one point. When you stented with a long stent in the diagonal, it was a little undersized statement. I think it was 2.75 on a 3 millimeter vessel. And second, I think you did a suboptimal dilatation there. So there's a part of the stent beyond the ostium which may not be very well approached.
Dilatation though. Yeah, I agree. We will have to optimize. We'll see what we can do.
That's what am I saying.
Deflate. See whether it goes. If it doesn't, then we'll take a new balloon. AJ, that is the nose diving for you, Dr. Mandar. Work.
He's strict. Thank you.
Deflate. So I think, yeah. So this is remember, this is a 2.75 stent. We are dilating now with a 3. We know it is a 3 millimeter vessel from IVUS. Okay, deflate. So we'll take the opportunity to optimize the distal with this. Yeah. 6, 7, 8, 9, 10. Yeah. Deflate. So this is 11 and okay, go up there. 6, 7, 8, 9, 10, 11. Deflate. And distally, I will leave the distal edge because it is a little bit in a plaquey area. So I'll just show you where I am and see, I'll I'll inflate it here. Yeah, 8, 9, 10. Deflate. Okay.
Devdutta, have you got a stent boost or a clear stent, whatever software?
Stent Viz.
Whatever. Now we have a clear stent view also where you can show it live actually.
He's working on G, so that's a good point that stent Viz or stent boost or stent imaging will give some fair idea, kind of an alternative to your imaging.
Okay. আমাকে এবার 3.5 এর একটা নিয়োগ দাও, এটা এখানে দাও।
The skeleton looks well expanded in the diagonal.
Yeah, I'll. Yes.
A bit, yeah, the different technique I usually take here, that I usually keep the 3.5 balloon which you want to take for LED now from before. That keeping a balloon 3.5 distal to the stand in the main branch is better because you have dilated the center segment of the diagonal too much.
I accept. Yes. I agree. We might have some, you're suggesting we might have some problem going down the LED.
Yep.
Yeah, it is very roomy, so I hope it will go down. But yes, I agree. I'm just rushing through the steps. I'm just cutting corners a little bit. I hope there won't be any trouble.
If you're not doing kissing here, you can remove the diagonal wire and you can go with the.
Yeah, that's a good suggestion. I can take this wire out. Diagonal.
After taking the balloon, you can take also, because this 2-wire proximal will help you for like a body or some partial body or something.
এটা diagonal. না, এটা LED. এটা LED. এটাতে পড়াতে হবে। এটা diagonal wire. I think we'll take this diagonal wire out. Okay.
Okay. In the meantime, I had a couple of queries to the expert panelists over here. Not in this case, because here the diagonal is very large, but there are times when side branch is relatively small but long length, and you do not want to go ahead with stenting the vessel, but you want to preserve that vessel. So how often do you use jailed balloon technique or modified jailed balloon technique?
Jailed balloon is described by Singapore people and Bangladesh people also do jailed balloon.
Japanese also. In fact, I did 2 back-to-back cases today.
No, Dr. Hajra, the Saito has also that he has modified the jailed balloon technique. So Saito is very much fond of jailed balloon technique also. But I am not. I don't like.
There are few precautions to be taken if you are doing the side branch gel balloon. The length of the balloon should be more than the length of the stent lying proximally, so that these 2 markers of the balloon, one at the side branch, the proximal markers should be away from the stent edges, so that the removal or retraction of the
12, 13, 14, deflate.
If you keep
Dr. Hajra, that one is the jail balloon technique, but modified jail balloon is different. Modified jail balloon, you have to take a small balloon and it will bear the stand in the ostium, not in the stented segment at all.
This looks all right.
So that one is you can take a very small balloon to preserve the ostium of the side branch.
No, what I'm saying, the retraction or retrieval of the jail balloon may be problematic.
Yeah.
It doesn't happen. That is what we always feel. But what they have described in modified jail balloon, they did not have a single case where retrieval was a problem. Not a single jail balloon got entrapped.
No, that will elongate. That will cause a not deformation, longitudinal shortening. That will elongate the stent because you are pulling the strut with the balloon behind your stent. So if you keep your marker away from the proximal stent marker, it is.
Yeah, Dr. Hajra.
Suggest
a proximal and distal landing zone for us.
Yeah.
Okay, so we are looking at, we have dilated. You can see that there is a dissection in the mid LED. So we want to go beyond that. So we can see a very small septal there from where we can stent it, because that looks a reasonable zone. Can you show
Can you play it?
Can you show that?
Can you play it?
Yeah, play it. And we can there. Can you see that very small septal? Very small, two septals, small septals there are. I'm talking of the distal septal. So if I land my stent there,
but you will have a less space for.
Hold on a second.
for
Hold on a
pot.
second. I will show you. এখানে একটা inject করো কৌশিক. So I want to.
Dr. Khan wants to know how long is the disease segment.
এই জায়গাটাতে I think there is a inject. There is a landing zone round about here. Disease, it is all the way disease. If you look at it with, you will find plaque everywhere. But I want to land it here because my next landing zone is down at the next septal. Can you see that? So maybe I can land it here.
Yeah, but Dr. Devdatta, you should have enough space for pot, enough length for pot.
Yeah. There is a lot of LED proximally. I am first looking at the distal landing zone. So do you think this is a good distal landing zone? Bolun.
Yeah, the distal marker of the balloon is the point where you can land the stent. You can finish the stent.
Dr. Ghosh, when do you land your stent distally and proximally?
No, I fully agree. The distally I agree with Devdatta where he's planning to land his stent on that marker because most of the vessel is diseased. So I think that's a reasonable place. And
proximally, do you want me to come up to that diagonal, first diagonal?
Yeah.
Or there is a bulge
I think
there?
so.
To that first diagonal, you want me to come up?
Yep.
Yeah, that is the better option.
Diagonal, yes.
So the current concept
also you will have a lot of space for pot.
Yeah. So current concept of high risk bifurcations are if you have an atherosclerotic plaque, vulnerable plaque, before bifurcation, for example, here, before diagonal 2, there is always a atherosclerotic vulnerable plaque, and you have to cover this plaque. And you have a plaque beyond this diagonal 2, this is less risky plaque. So if you just keep your stent as you have mentioned, as Dr. Devashish Ghosh also agree with me, the distal landing zone is perfect, but it's better to go little proximally so that any future event in the proximal segment cannot be so devastating because your D1 will go, the proximal will go, diagonal will go.
We'll take a 3x48 and then we will optimize.
Right. Yeah, that's I also was dreaming actually.
All right. Okay, I think that is a good suggestion. We will do that. Yeah.
You are taking 3 or 3.5, Dr. Dev?
3. We'll take a 3.
Yeah,
because
that's good.
we are going it quite deep down into the mid LED. We don't want to.
Yeah, distal reference diameter is not more than 3.
We don't want to cause an edge. Even on IVUS, it looked 3 in that region. So we are going to take a 3.
And giants will be very appropriate stent if you really have a marker on the balloon with the stent, exactly on the stent. All the giant series, they have 81 micron thickness. It is basically DPDS, the fluoropolymer, fluoropassivation. And the beauty of giants is their stent is exactly on the balloon marker. So it will be very easy to place exactly where you want to place.
And also very expandable.
Yes.
Yeah, I think we have expanded 3 millimeter stents to up to 4 millimeters without too many problems. I
think for discussion's sake, the expandability, the Ultimaster is, I think, the best. You know,
yes.
From it can go 2 millimeters. So I think we have to actually call it that Ultimaster stenting. That's one of the favorite stenting in main stem, where you can really blow up a 3 millimeter up to almost 5. So
yeah, rule of thumb in that Ultimaster Tansei 2.5 plus 2, 4.5, 3 plus 2, 5, 3.5 plus 2, 5.5. And the side branch, I mean the cell surface area at the side branch is the largest with Ultimaster. But again, the giants is not bad stent, as I said.
I think it's just right. Just right.
You know,
Eleocaudal
Dr. Devashish, how much you actually you want? They're writing it down, but you know that you never take a stand to that 2.5 and you are going to up to 5.5. We don't do that one actually. We need 1 millimeter maximum to expand.
It's a rule.
Oreocranial dakha?
Safety margin, because with stent deformation now being a real story in a lot of the older generation stents, I think if you have a safety net, no, I don't do that. I would go for a 3.5 up to a 4.5. So it's very unlikely that LED will be 2.5 and the main stem will be 5. Very unlikely. So
steep
I don't do that. But if you have that safety net,
okay, we are about to implant our stent, so you can
just
take a look at it and tell us whether we should just go ahead. I think we are okay. What do you think? Yeah, go up. 6 of the auto epicranial. Oreocranial esho. Oreocranial esho. I hope we have covered the proximal distal adequately. I think so. If you look at the, can you see both the screens? No, you can't. So I can see both the screens. So I usually match it with my. Can you show them this screen? No, is it possible? Not possible. Okay. So this is only at 6 atmospheres, and I can see that the distal stent has opened up really. So I'm not going to go up too much. Go up to 8, and then we will deflate. Go up 8, deflate, deflate. Ki hoche? Ki hoche? আবার বাথরুম পেয়েছে শুয়ে হবে না একটু 10 মিনিট অপেক্ষা করুন হয়ে গেছে আমাদের কাজ হ্যাঁ Okay, so I am going to show you how it looks distally, and I think it's quite okay. I'm very happy with that, and I'm going to just pull this balloon a touch because proximally the vessel is quite large. I'm not worried about causing edge dissection or balloon contact. The balloon won't even contact the vessel there. So go up to 10, 11, 12. Okay, and deflate, deflate. So now we are going to, before we take that wire down the diagonal, we are going to optimize the proximal LED. So give us a 3.5 millimeter balloon, and then we will take the wire in because the proximal part of the stent is not optimized, and you can go underneath the stent if you try to wire it now. So I'll first optimize it. Okay, 3.5 balloon দাও হয়ে এসছে একটু সবুর করুন হয়ে গেছে Patient has been lying in the table for quite a while, so he's just a little restless now. একটু দাও না একটু মিডাস দেবে So now the test is, of course, being able to cross the stent a second time. I hope we will be able to do that. But let's just first optimize it well. The stent. It is important to do it. Yeah, এখান থেকে শুরু করো 8, 9, 10. This 3.5 তো 11, 12. Okay, deflate. Okay, এবারে এই জায়গাটাতে go up here. 12, 13, 14, 15, 16. Deflate. Okay, and এইখানটায় hold on a second. We are inside, তাই তো? Okay, go up. 16, 14, 15, 16.
How much
17,
high is the high
18,
for you
19,
for
20,
high atmospheric pressure?
24.
How high you go?
Deflate.
High atmospheric.
Eleocaudal, please. Eleocaudal. আমাদের সেকেন্ড ওয়্যারটা দেবে আমরা ডায়াগোনালে রিক্রস করব
Dr. Khan, how high is your definition of high atmospheric pressure?
Yeah, it is actually because I never look at the RBP.
Can I stent acha to?
I never look at the RBP. I go up to 25, 20, 26, 28, 26 at least in NC balloon. I don't care what is the RBP is.
16, 18, 20, 24. Deflate.
Dr. Padi,
Sir.
how high you define the number is high for your high atmospheric pressure dilation.
Sir, I usually didn't much go for very high pressures because I have seen the people who has pressure.
No, what I'm saying, asking you, what is the definition of high by atmospheric number? Give us a number.
Usually more than 24, sir.
Dr. Devashish Ghosh, what's your number?
ঠিক আছে huh wisdom we are trying to make sure that we are dilating that last bit of that proximal part of the stent, huh? Okay. Here. Oh. Okay. Sorry. এইখানটাতে তাই তো রাখা হ্যাঁ ইনজেক্ট ঠিক আছে এবার হ্যাঁ ওকে দেখো he's a heavy man, that is why I can't see the আচ্ছা না এটা করা যাবে না দাঁড়াও
If you have a stand boost, you can check the stand boost.
Yeah, we are trying to do that. That's a good suggestion. Inject. এখানে ঠিক আছে তো? Okay, go up.
A bit distally maybe.
We have gone a little bit distally.
Yeah.
এই জায়গাটা আমরা ভালো দেখতে পাচ্ছি আসলে এপিকর্ডাল এসো তো I just want to see that proximal stent edge properly. এটা ভালো
ঠিক আছে
এইখানে go up. Everyone happy to?
Yeah.
So Dr. Ghosh, what is your definition of high atmospheric pressure? What's number?
18, 20, 24. Deflate. So এখানে আমরা একটা স্ট্যান্ড বেস নিচ্ছি
high atmospheric pressure I think is very relative and I think it depends on what you are trying to achieve. So basically if you are operating on a small vessel, your high atmospheric pressure is one, and in a large vessel I think you can go up to 18-20 without any problem. Depends on, but you wouldn't try that on a side diagonal branch of going up to 20.
No, what I'm saying, if you really tell your fellow that this is the high atmospheric pressure. So what number you do give, the range? Now if I have the range.
Now, basically, if you're saying you're working inside a stand, isn't it, for deployment?
আর 10-15 মিনিট
So it depends on so many things. It depends on anything above 16, I would say, is a high atmospheric pressure.
Okay, so 16 is the lower side, and it can go up to higher extent if it is calcified and fibrotic, expanded. Yeah, you can go up to 50 atmosphere with the opium balloon. So this is not a fixed number, but definitely it can have some number on the lower side, not on the higher side.
Yeah, but Dr. Hajra, you know that NC balloons, how much you will inflate, that is not going to be that much bigger. It will be just in a pressure will be high, but not that much bigger. Like a compliant balloon.
Every balloon is a compliant balloon. Now, non-compliant balloon is also compliant by 10%.
Yeah, only 10%, not that much.
So you can't say that it is a non-compliant. It is a compliant by 10%. Opium balloon is compliant by only 2 to 5%. And
yeah, it's just like NC.
Now, one of the strategy why we go for a high pressure deployment is that during the initial part, when you are stenting from healthy to healthy segment, there is disproportionate expansion of the stent. The disease segment might not expand so much, but the healthy segment actually expands at a much lower pressure. And if you do a high pressure at the edges in the normal segment, your chances of edge dissections are there. So high pressure is where you think that the stent is underexpanded in i.e. that is mainly the disease segment where it is fibrotic, where it's going to yield much less. So if you're doing healthy to healthy segment, the healthy segment always opposes very well, even with the nominal pressure of the stent. But it's the disease segment where it is fibrotic disease, even with the nominal pressure, the stent opposition might not be there at all.
Okay.
So you know what, Dr. Debashish, what I tell to my fellows is that against resistance, where the balloon has got higher resistance, like that part of the discrete part of the lesion or a small 5 millimeter part of the lesion, which is really, really very much resistant. And that part you will go how much you want. That at least the balloon is not rupturing, but in other parts, like a peripheral stand, like a auto, they accommodate the place automatically, that you don't need to inflate that much there. So that one is okay. But against resistance, that one you don't know how much is the resistance. So you will see, and you will increase the pressure.
So if I ask you one question, Dr. Khan, by OCT criteria, what will be the best criteria to finish the case for the best outcome in the long term as far as the MLD max the concept is concerned? So what will be the MLD or MLA on OCT? And what are the criteria, if you can elaborate to the fellows?
Yeah, that one is actually, the numbers are always it's very much special. For left main is okay, but for non-left main, you can't actually figure out that what will be the actual number there. For left main, you have a number and you can tell that this is the number, even in the Asian population or in the smaller left main caliber. But for non-left main, it's really tough. You will have to measure the MLA before stenting, that you have a MLA, and also the even arterial dimension also up to the media. So you can predict that how much is the lesion severity there and how much fibrotic or calcific there and what is missing there, because the lumen you can achieve by stenting, and you may not be happier because you need more actually there to put. So so you know that this is comparative.
MLD, you know, distal reference vessel diameter, suppose it is 10 millimeters square, the distal edge of the stent should be 9 millimeters. You have the best, and the proximal MLA of the reference vessel diameter is 10. Then your proximal edge of the stent should be 20%. That is 9 millimeters. So that is the gold standard. But achieving 80-85% is also very good. Anything less than 80 is not good. 4 millimeters square in the circumflex left main, and 5, 6, 7, 8, 9, as Dr. Khan has mentioned, but bigger is better.
Yeah.
1.5 to the. So we have managed to recross into that diagonal branch. Usually this is the most difficult part of DK crash, recrossing the second time.
Not in your hand.
If we have done it, it's a diagonal. It's a LED, no? Change column. Huh? If you are able to do that, then I think.
Yeah, if you can recross the diagonal after having 2 layers, 1, 2, 3 layers of stent in 5 minutes, you are a expert operator like Dr. Devdatta, and if I cannot, then you are expert like me.
You know, that's a test. Like,
let's see whether the balloon will go, and if not, then we will do OCT again.
And Dr. Khan processed the diagonal branch without even seeing the angiography. I mean, that is, he is the Superman then.
Come on, I would be in that case, I would be next to God, and I will tell him that, yeah, you are very much helpful to me all the time. You know, that this two rewiring is very much,
crossed, so
fortune is necessary here.
Go up. 8,
Little
9,
bit
10,
of luck
12,
is also
13,
necessary for
Yeah.
recrossing.
14, 15,
It's
16,
not always
17.
technique.
Definitely.
What's your comment of recrossing? What are the tips and tricks of recrossing strategy for the balloon?
Here. 8, 9, 10,
Yeah,
11, 12,
balloon,
13,
I think the
14.
first crossing is my idea when you're
Deflect,
crossing in a
deflect.
decay crash, use new balloons. I think that is very essential. Though we try to economize with our country for aid,
Torkata
but
LED
use
wire
new
আছে?
balloons. I
তাই তো?
also try to use balloons
Okay.
with single
Okay.
markers. That is much more sort of easily crossable.
তিনের
And I
বেলুন
think
দাও আর সাড়ে তিনের বেলুন দাও।
most wire supports are pretty good. With the standard wire, the wire support, changing the wire support doesn't help a lot in recrossing.
Okay.
I think it's the balloon profile.
So Prakash,
so I think
we are going to conclude. So I'm going to take a 3 millimeter balloon in that diagonal and a 3.5 in that LED. We are going to do a kissing balloon dilatation, and then I will optimize the proximal part of the LED stent with maybe with a 4 balloon. But before that, I will do a OCT.
Right.
So this is the thinner balloon. So this is the 3 balloon going down. This is a reused balloon. So I hope it will go down and not force me to open another balloon. Yes, it has gone. So,
Yeah.
okay. Now,
I don't know, Dr. Hajra, how your corporate hospitals are working. What I usually do in our hospital, we take the count of each operator in a month, that how much balloon he has used against the case number of the PCI, so that I usually put the balloons, newer balloons, for the bifurcation and the complex lesions, like 5 or 6 balloons without any extra charge. And in the simple lesions, I usually do without balloon, so that I can keep that balloon in a month for preservation for the complex PCI. Is it working in that way in your corporate hospital or not?
The balloon democracy, we say that everyone has a right.
You will get prize.
Nobody has democratic right to use new balloon in private sector.
No, balloon don't cost much any longer in our country. So there was once a time then when the balloon used to cost 25,000, but it is now available for 8,000 rupees. So
yeah, in our country also it is 8,000 now, but yet you know that the corporate hospitals always count even a single penny.
Yeah.
No,
I agree. With the cost of the balloon coming down, I don't think we should be forced into making our procedures more difficult, more jeopardous for the patient. I do not believe in that philosophy. It is better to counsel your patients what about the cost it involves and how much the balloon charges are. I do not think you should really compromise your procedure by trying to
agree. Not only to the patient, to yourself, like you get
absolutely. Radiation time, everything goes up. Radiation time, technician fatigue. In the middle of a night, you're trying to do a primary PCI and you're asking that you use an Oxford balloon. I think that's not fair. Not fair to the patient, not fair to the operator, not fair to the cath lab system.
That's I'm telling that for bifurcation, for complex, for calcified lesions, you will put whatever the balloon you need. Yeah. Use that one, because make it easier, make it with a shorter time, with less contrast event. Radiation is also a factor that's a big factor, obviously. But what I do that democracy is there, that for simple lesions, whenever the balloon is, you can take that Oxford balloon and use that one and keep the balloon for bifurcation or for complex lesions.
Yeah. Also, you see, the patient is more worried about the total cost of the procedure, and that has come down with the stent cost coming down. The total cost of the procedure actually has decreased over the last 10 years in India. And that is why I think it's easier to use more New York hardware.
But for health, the people of this part and that part of Bangla is something like that. The more you are lowering the cost, they want more.
Absolutely.
While Dr. Devdutt is working, we'll take another few minutes to finish this case. My esteemed colleague has joined, Professor Dr. S.C. Mandal, Dr. Anand Raman, Dr. P.K. Shahu, and within 5 minutes, we'll start our next session. And we'll have OCT guided IVL assisted Left-main stent PCI, OCT in calcified stenosis, a case-based discussion by Dr. Sahu and Dr. Anut Raman.
Okay, go up.
And we have coronary physiology.
Okay, yeah. You go ahead, Prakash. We are just doing our kissing dilatation. Go up.
Yeah, you have another 5 minutes to finish, sir.
Okay. All right, thank you. So that is the second kissing. Okay, deflect.
It gives me immense pleasure to introduce Dr. Sanjeev Rai, Dr. Jabir, Dr. Devdatta Bhattacharya will join us very soon, and we'll be starting the next section within 5 minutes.
We're just waiting for Dr. Javed and Dr. Sanjeev Rai to join. Maybe they'll be joining in a couple of minutes.
So what do you think? We have done the kissing. I think we should not be doing anything more here. I'll just take the diagonal. Which is the diagonal? Teenage balloon diagonal. We'll take the diagonal and wire out, and we will. This is the LED. So this is the diagonal. Okay.
Also, Dr. Kuntal Bhattacharya, he will be speaking on FFR, RFR in complex.
We are just going to optimize this LED stand.
Any question from any other panelists who has joined recently? To summarize this case, Dr. Devdatta Bhattacharya has shown is a complex bifurcation lesions where the diagonal is of reasonable, rather a very good size, large size diagonal, long segment lesions, very critical lesions, the LED and the diagonal. He has imaged both the vessels by intravascular ultrasound, took the help of OCT to know the crossing of your side branch, and he initially crossed distally, and later on in PK class he tried to cross proximally, but we do not know exactly what level he has crossed, but he has crossed with difficulties. He has used all the gadgets necessary for a live, beautiful live demonstration, and he has followed all the steps meticulously and shown us that if you follow each and every step meticulously, take care of the lesion, take care of the imaging, take care of your wear and guide. So you need a teamwork, and you have to keep your mind cool. So if you have any complications, be prepared. But most of the times it can be done with a lot of safety. If you have two large vessels, bifurcatings, as Dr. Khan has mentioned, it's much easier to do in the left main. But doing bifurcation in the DK class in the distal vessel or in the circumflex or in the distal arch is much more difficult. So it was a difficult case, but he has done it so elegantly that the result is going to be beautiful for the long term. And we would like to thank all the panelists. Please stay with us, and we'll ask a last minute comment from Dr. Ghosh first, Dr. Khan, and other doctors like Dr. Padi and Dr. So first, Dr. Ghosh, your final thoughts on the case?
Yeah, I think it's an excellent case, and I think the amount of difficulty that was in the case, you will come that on a regular basis. So do not be disheartened by it. This is usual, like crossing a crash tent is not easy, but you should try and persevere with it. Do not give up. And at the end of the day, as the doctor has shown, that the results are very, very rewarding. And I absolutely agree. You have to protect that fairly big diagonal branch. I don't have much more to say. And only the antiplatelet strategy should be fairly aggressive in this case. That is my last.
Right, Dr. Khan, what's your learning, or your learning, and for our learning, if you can summarize final thoughts from your side?
For me, just whenever I see a DK crush, then just I think that this is really a complicated case, no doubt about it. So the complicated case of what the Dr. Devdatta has done is really beautiful in a beautiful way. And also the vessel, the dimensions, and also the position of the stents, everything was very good, which is very much important for this things. And along with the polygon of confidence should be better, which we have seen in the picture is really good. For DK crush, yes, I will tell the fellows all the time that don't miss any step. Always remember the step, or tell the operator not to miss any steps of the DK crush. That's all I can say. Thank you.
Okay.
So friends, that's all we have in the first session. a live case. And thank you, Dr. Devdatta,
Thank you.
Rabindranath Tagore Hospital, for showing us a beautiful case along with your team. Thanks to your staff, technicians, and the patient himself, who has given us a lot of, we have given him a lot of discomfort by listening to his pain. And thank you very much for the for beautiful case, and thank you all. And special thanks goes to the patient himself. Now we'll move on to the next session. Let me introduce, as I introduced Dr. Sanjeev Rai, I can see Sanjeev here. Dr. Jabir will be joining very soon. If you have joined, please say hello to us. And from our side,
hello, Dr. Hazra. I am here. I have already joined.
Yeah, great.
Good evening.
Greetings from Calcutta. I mean, it is
you.
a city of COVID. Now we can say we are two COVID cities joined together.
It's a dear and near city for us.
Yeah, near cities for both of you. Dr. Sahu, Dr. R. Anantharaman, and Dr. S.C. Mandal. He is a professor and is the director of cardiology, SSKM Hospital. And everybody knows who Dr. R. Anantharaman is. He'll be speaking on OCT guided IVL assisted left main stem PCI. So Anantharaman, we met just few days back. He's a tremendous guy. I mean, understanding of the hemodynamics, understanding the complexity, and to present it so simply to the fellows, to the colleagues, and he's a masterpiece. I mean, he is so brilliant. The degree is not going to tell you. He's much larger than his degrees and qualification. He's a great operator, great orator, great scientific man. So it's immense pleasure to welcome Dr. Anantharaman. Over to you, sir.
Thank you, Dr. Azra. It's a pleasure to be in Kolkata Live, and thank you for all the organizers for this opportunity. I'll just share my screen. Can you see my screen, sir?
Yes, go ahead.
Yeah. Now this is a live in box, but I will scroll through the. It's a live in box.
Okay, go ahead.
You see it?
Yes.
Yeah. So I will scroll through that in between to cut it short at 12 minutes, so that we'll have 2 to 3 minutes discussion. It is a distal left main and calcified previous bypass. So we'll be discussing on the image guided optimization and what techniques to use for calcium modification. Fortunately, the hospital I work in, Kaveri, it's got everything. We got laser, we got rotablation, we got IVL, everything is. So that you don't need to go with a sort of pre-prepared. You just go and do the image and then decide on the table what you need to do. So it's a OCT.
And dyslipidemic and history of CAD since 2015. And it was a post CABG. It was off pump 6 years ago. The graphs were Lima to LAD, which was an onlay patch, and SVG to PDA. And post which patient was normal. And next slide, please. Patient came with 3 months of exertional chest pain. ECG was normal. There was only poor RV progression in the anterolateral leads. In the echo, it was a concentric LVH with good LV function, and there was a normal valves. We did the treadmill test for the exertional chest pain. It was significantly positive for inducible ischemia. There was a significant ST depression, around 2.5 mm depression. And we proceeded with angio. It showed calcified vessels. There was a distal left main 70% stenosis, and LAD there was a proximal 80% and mid 100%. And LCX there was a proximal 80 to 90% stenosis. And RCA there was a 80% stenosis in the proximal RCA. The graph study we did, it showed Lima to LAD and SVG to PDA. It was patent with good distal runoff. And later we planned for image guided PCI to LF main to LCX.
So the heart team discussion happened between the cardiologist, myself, Dr. Gopala Murugan, as well as our cardiac surgical team. And given that he's got a patent Lima to LAD as well as vein graft, it was decided to go with image guided PCI from left main into circumflex. Do your imaging first, OCT or IVUS. Once you've done the imaging for the OCT guided, you assess the arc of calcium, whether it is 180 plus or the depth of calcium around 5 millimeters or more, and the length of calcium. Then depending on that, you can decide on whether you want to go ahead with sort of a simple balloon-based approach, like a non-compliant balloon or cutting balloon. For calciums which are more than 180 to 270, more than 5 millimeter depth, and also more than 5 millimeter length, it's better to modify it. So the depth of calcium is high means IVL is better. If it is superficial calcium, then we can do with rotablation and laser as well. So that is what this algorithm is. But each stage you need to assess with the image. So you do the image first, you do the modification, you do the image again, see whether it's modified well. Then you use a 1:1 non-compliant balloon, see whether that balloon is fully deflating. Then you put your stent, then assess again to see whether the stent is properly opposed. Then you do the image. So that's what we are going to do today, and based on this algorithm. Next slide, please. Next slide, please. So OCT sort of wins over IVUS in the specific cases. Previous one, please. As you can see, it's got all the box ticked, especially for the severe calcified lesions. It will give you the depth, the length, arc, and all the information you need to decide. The only thing is the patient need to have a reasonably good creatinine level, and also ostial left main will be difficult. All the other lesions we can assess properly with the OCT and decide on modification followed by that stenting procedure, and a very good outcome, which has already been shown in multiple studies. Next slide, please. Now this is the angiogram done on 23rd of April. Obviously this shows the Lima shot. Next picture, please. Go to the next. And there's a heavy calcification seen in the coronary fluoroscopy. Next slide, please. This also shows the angulation. It's around more than 90 degrees angulation in both caudal views from left main into the circumflex. Next slide, please. And the LAD after the mid vessel is occluded, but it's been supplied by the Limograft. Next slide, please. So initial discussions we had, we were discussing whether we should sort of deal with the LAD as well, or we just keep it simple and go with left main into the circumflex. And the consensus decision was, given the large territory with the circumflex and also patent Lima to LAD, we felt that it's better we'll just do the left main into the circumflex and not complicate it too much.
So I'll just go to the OCT now, and because the OCT is very, very important, you assess the OCT with the algorithm, MLD max approach. MLD is the morphology, length and diameter. And then once the procedure is done, then you assess with the max approach. That is a medial dissection, apposition, and expansion. So for the purpose of time, I'm scrolling it forward. So I'll show you the length and the morphology. This was the morphology. There was heavy calcification. So we are going from left main into the circumflex. There is calcium, and here there is nodules of calcium protruding into the vessel, and here there is more than 2 from the arc calcium, just only about 30 degrees left. And if you go a little bit into the circumflex, almost 360 calcium, but the depth is almost here more than 10 millimeters.
So there are chunks of calcium.
So the length, the depth, and the arc, everything was high. The score was high, OCT score was high. So here, based on this pre-imaging, we decided to have IVL as the first option. And to get the IVL balloon itself in, we have to prepare it at least with a 2 millimeter balloon, because there were areas of just 1.8 lumen. So that's what we did before taking the IVL. A 2 millimeter balloon was taken, and that is a 2 millimeter balloon, non-compliant, just to make enough room for the IVL to go in. And this is the IVL part.
Yeah.
You can see in the ECG, when you are giving the IVL pulses, it's almost like a paste.
You can see when the pulse is delivered, that electric disturbance in the ECG. Yeah.
So most of the pulses were given where that tight lesion was.
Yeah.
And once the IVL was done, then again re-imaging was done. And that showed there were enough cracks made in even in the parts where there was deep calcium. We can see the cracks made, deep cracks. And then a 1:1 balloon was used after that to assess the dilatation. Once it was comfortable, then a stent was placed. It was a 4x20 and it was an onyx stent.
Main into the circ.
Left main into the circ. And following that, again imaging is done to see whether the stent is fully deployed, and then optimization was done in the proximal left main with the 4-5. And again, this is a repeat imaging, a final. So here there was molar position. So 4.5 was used to optimize. And the 3D reconstruction view to show
Team of your branch and where you are crossing when you are doing a sort of bifurcation stenting, it will tell you whether you are crossing the proximal or distal stent stud. And you can also see the stent stud across the LAD ostium here. So that's what he's trying to show.
So, but there was enough orifice there.
There's only one stud that we can accept.
Once the result was satisfactory, the final angiogram was done. Yeah, that is the final angiographic result. So it is 7:18 now. So we got 2 minutes. I'll stop there. So that is image guided IVL assisted distal left main stem stenting for a heavily calcified coronary artery disease. Thank you.
Thank you, Dr. Jabir. If you can open the discussion.
Yeah. Yes, Dr. Anantharaman, a fantastic case, and moreover, it was I think an optimal decision, the correct decision, because you did the imaging, you look at the calcium, and the calcium here, the major thing about the calcium here is not much of the superficial calcium which warranted a rotablation. And not only that, it's a decent lumen, big left main, big circumflex, where a wire bias, it will be difficult to cut the calcium also. I think the correct decision was a lithotripsy, or for that matter, even if the lithotripsy is not available, I may think about an OPN balloon also. And mostly it was a deep calcium rather than superficial calcium. So the ideal option was lithotripsy, and you went ahead with the lithotripsy. Excellent crack at the calcium, and he put the stent well expanded without any malopposition, without any lumen issue, without any edge issue, and finally you could achieve an excellent result. It's a protected left main, so I will not worry too much about the left LAD. Even if multiple struts are across, I will not touch it, because there is a good lima flowing and distally supplying the LAD very well. Only thing is there is a diagonal, but that diagonal is also supplied well. I don't think there is any point in crossing the struts for a protected LAD. So you've got a fantastic result. Great decision. There is no need to comment on anything. I think I would not have, I would have done the same way. Only thing is I would have used the Amplatz catheter because of that extreme curve of the circumflex, but your stent moved in very well.
Right.
Great.
Dr. Rai, Sanjeev Rai, if I bring your expertise, would you go for 3.5 IVL or 4 millimeter IVL in this case? Do you think the circumflex oste is nicely done or underdone?
I'm sorry, Dr. Hajra, because of the net connectivity, I missed.
Okay, so what I'm saying, would you go for 3.5 or 4 millimeter IVL in this case? And what do you think, in spite of angiographic good result, the circumflex oste is nicely done or underdone?
I think it is slightly done. It could have been expanded to a larger diameter, looking to the reference diameter, if I'm not wrong. But I might have missed a couple of frames because of the net connectivity. Just correct me if I'm wrong.
Yeah, Dr. Anantharaman, you can explain to him what are the points he had.
Dr. Asra, correct me if I'm wrong. I thought they post-dilated it with a 4.5 millimeter balloon.
Yeah. I was going to just exactly say that. IVL choice, it could be 3.5 or it could be 4. The only reason to take 3.5 was the OCT showed where that the maximum calcification, 360 deep calcium, the lumen was only 2. So obviously you can go with the vessel size or you can go with the lumen size. I wanted it to be safe. So 3.5 and all the pulses were delivered. Most of the pulses were delivered because in the left main itself, there were only patchy calciums. So we are not modifying the left main. We are modifying only the circumflex in this. And after that, a balloon dilatation was done. A 4 millimeter non-compliant balloon was used in the ostium of circumflex. Once it was fully inflating, only then we went with the 4.5 in the left main. and the final OCT was done. Otherwise, 4 millimeter IVL also will work, but here I was satisfied with what we got, and it was fully expanded, 4 and then a 4.5 in the left main.
But I think with 3.5 balloon, once you have demonstrated the cracks, and then subsequent things are easier, it doesn't matter to escalate your balloon to 4 or 4.5. I mean, that's the most important, that you should be able to crack the calcium.
And
Yeah,
Dr.
so
Sanjeev,
even if it is done with
my question is to you, whether you should use 4 millimeter 1:1 ratio of IVL or 0.70:1 IVL in left main.
This is ostial circ. Left main, we're not modifying in this case.
Okay.
And Dr. Hajra, recently we had an interesting discussion regarding that point. So one of the Dr. Chadda was pointing out, I thought it is a little interesting point. That is, when we use an IVL, we are not basically looking at the reference vessel. Where we need the action of IVL is the most disease segment, where you should look at the disease segment diameter. The balloon should oppose clearly to the vessel wall, so that the pulses should be transmitted properly to the vessel wall. So there may not be any requirement of deciding on a balloon size based on the reference vessel. It is based on the diseased vessel, maximum diseased area where you are going to hit with the pulses. Otherwise, there is a chance of the balloon rupture also. We have, of late, we are seeing a lot of balloon ruptures. Dr. Sanjeev and Dr. Hazra, what is your viewpoint on it?
I think that point is very well taken. I mean, what you have explained, it is the vessel should be, the balloon should be snugly fitting the vessel where you need to, in the heavily diseased segment where you need to crack the calcium.
Dr. Mandal, if you have any thoughts on this case, Dr. Mandal, unmute yourself. Unmute. Go ahead, sir.
No, I think this is excellent performance. In fact, balloon size, that what you mentioned, that 3.5, in fact, it is good. And ultimately, the result is also very good. Regarding the calcium, it is not superficial calcium. So IVL negotiation and everything, I think, is excellent.
Right. So I think if you have calcium nodule, I think
webinar আছে
in calcium nodule, one balloon may not be sufficient. So be prepared, like an extra balloon, like you have to give maybe more energy, like 4 millimeter balloon or 3.52 IVL balloon sometimes. So it's not that, because of the economic cost, people cannot afford single balloon now. It's a far cry to have 2 IVL balloon, but we have used 2 balloons in sometimes when you really need it to finish the case. So any final thoughts from the Dr. Anand Raman? Do you want to add something in the case?
No, when you're going to use 2 balloons, I always tell the company, if the balloon ruptures, then you are going to give one free of cost, because it's 2.75 lakhs. And if you're taking a 3.5, the balloon ruptures, or if you've taken a 4 and the balloon ruptures, you want to undersize to 3.5, then yes, it can be done, but the company should be able to cover it. It's like the TAVI. When you put one TAVI, if it's popped out, you're putting a second one, and the cost is the same. So that the company
your final thoughts on calcium nodule, like it is
nodule, it will rupture, sir, because it is well proven that IVL balloons can rupture. It's rare, but still 5% is possible, and you should not be put off by that. I think you go with the next IVL, bigger size, and it will sort of sort out the nodule.
Right. Thank you very much for your wonderful case. Can we move on to the next case? Dr. Sahu, are you there? Dr. Sahu? Yes. Great man. Nice to see you.
Hello.
Dr. Sahu, everybody knows that he is a great operator in Odisha, and he's a professorial figure in eastern part of India on imaging, complex PCI, difficult PCI, teaching juniors, seniors, colleagues, and he's a learned man. He is MD/DM for CP, FSCC, FCCI, and so many things. He is larger than his qualification, as I said about Dr. Anand Raman. He's from Apollo Hospital, Bhubaneswar, and his talk will be OCT in calcified stenosis, a case-based discussion for next 12 minutes. Over to you, sir.
Thank you, Dr. Hajra. Let me first start off that we know that whenever we do a coronary angiogram, we hardly detect calcium unless there is a tram track calcium. And for this, definitely to see a deep calcium, superficial and nodular calcium, and to do a calcium score, we all need an OCT. Now, basically, when you do an OCT in calcium analysis, remember we have to take 3 steps. What is the site of calcium, extent of calcium, quantification of calcium. Now, the site of calcium may be superficial, maybe deep, or maybe nodular. Three types of sites can be there, and it can be an eccentric one or can be a concentric one. And lastly, when you have to quantify the calcium to put it into a score, you have to see what is the length of calcium, what is the this thing, whether it is more than 5 millimeter, what is the arc of calcium, it is more than 50%, and what is the depth of calcium, it is more than 0.5 millimeter. Now, deep calcium is something which we have started realizing after using more of OCT. There is a presence of a thick fibrous cap, and this calcium is non-luminal. This is very important. And this score, we know that if it is 1 to 2 points out of all these 4 points, then we go for a high pressure balloons. If it is 3 to 5, lithotripsy, and if it is uncrossable lesion, it is rotational atherectomy or orbital atherectomy. The first case, see, there is this thing that is a very calcified lesion that you see, and OCT was done. And when we see the OCT, we can see that there is some amount of deep calcium and also some amount of superficial calcium. Going to the analysis of the OCT, this clearly shows that there is some amount of superficial calcium, and also you can see deep calcium. So here what we decided was the score was not high, it was between 2 or max 3. So we thought that we'd use a cutting balloon because there was some passage. We did the cutting balloon, and after that did an NC balloon. And after doing the NC balloon, we put a stent, and definitely looked very good. Of course, there was some compromise in the diagonal, but we accepted it. But when we did an OCT, what we saw was that basically the calcific part had not opened properly. But in angio, we could see a very good result. And here you can see that it is not open, it is a malapposition. And there is what we took, thought that OCT did definitely help us in picking up this malapposed part where it was not greatly opposed. So what we did was we took an OPN NC and then gave a high pressure dilatation, and this is what was the final result. So these are cases where calcific areas can easily be tackled with an OPN NC balloon, and the results ultimately are fine. So this is a final result to show this thing that is OCT, how this stent has been very well opposed and well expanded. Now, the next subset that we get is uncrossable lesion, like a case like this who comes with a strongly positive TMTS single vessel disease and a very tight lesion, and you can see a tram track calcium over here on the fluoro. And here definitely the question would be to go for a rotational atherectomy or an orbital atherectomy. So I've dealt with the high pressure balloons or the NC balloons, and I come to the rotational atherectomy. And this is what we did, just did a rotational atherectomy first initially. And the results were not very great, but when you do OCT, you can see that the rotational atherectomy has definitely worked. If I show you all the places where the rotational atherectomy has done the chipping, but still a lot had to be done, and then we used high pressure NC balloons, and post NC, this is what we saw. We could dilate the very non-crossable lesion after rotational atherectomy and a high pressure balloon dilatation, and then post NC, we again did this thing that is OCT just to see how it had expanded. There was definitely areas which had expanded very well. Then went ahead to see the phase-wise analysis. The area was very significantly increased, and then put the stent, and this was the final result. So this was the second subset where you have to use a rotational atherectomy when in uncrossable lesions, and you can escape and then do NC balloon dilatation and finally get a good result. So this was the final OCT analysis of this case, in which it was an uncrossable lesion where a rotational atherectomy was done and a full stent was implanted, and you can see it is well expanded and well opposed. Third case, the third subset, where as Dr. Rajaram has already shown, where you have, this is a patient of diabetes, hypertension, dyslipidemic, TMT positive, calcific, this thing non-significant lesion in LED. SERC was ectatic and was very calcific. And this is what you can see. The SERC is a calcific SERC, and there was two things. There was ectasia and calcification. And if you try to analyze the OCT, I'll just directly go in the interest of time. You can see what the OCT shows. There is not only deep calcium, there's superficial calcium, and you see the arc of calcium is quite big. So definitely, if you try to analyze this case, there's a big chunk of almost more than 180 degrees calcium is there, and you can see the depth is also very high. The arc is more than 180 degrees, the depth is more than 0.5 millimeter, and of course the length that you see is around more than 20 millimeters. So here comes, based on the classification, that if you try to put a scoring into this, it comes to the score of 4. And with a score of 4, we go to actually we think of a lithotripsy. And that is where we started thinking of using a lithotripsy, took a 4 millimeter lithotripsy balloon and had to give all the pulses in sequence over there. And then this is post lithotripsy, post IVL, that you can see there's some dissection there. And then OCT has been done after this lithotripsy, where you can see that there has been big chunks, and also there has been a lot of dissection and cuts you can see here. And this is what are the results of beauty of doing a lithotripsy in very deep calcium. So the calcium fractures are very clearly seen, and you can see the calcium fractures very clearly, and you can see the area has increased to 6.94 millimeter square. So the next part of the job was to just to put a stent. So we was pre-dilated with the 4 mm NC balloon. 4 into 32 synergy was used, and this was the final results after the synergy has been given, and was post-dilated with a non-compliant balloon. So this is the final result, where you can see that both the ectatic and this thing that is stenotic calcific lesion has been well opened up based on strategy chosen on the this thing workhorse this thing chart. And here this is the pre-stenting result, and this is the post-stenting result, and finally the OCT done again, which shows you that the stent is well apposed and is well expanded. So if you try to analyze that, there is a good stent apposition and there is a good stent expansion. This is what you see. So these are 3 examples of cases how you deal with calcium. If it is a non-crossable lesion, you go with a rotational atherectomy or an orbital atherectomy. If it is a deep calcium, the score is more than 3 to 4 or still higher, then you go for a lithotripsy balloon, and if the scores are low, then definitely you go directly for this thing NC balloon. So calcium is something, as I say this, it is like calcium is sitting inside, and you never know when you'll hit it, and when what you don't see can lead to disaster. So it is very important that you do an OCT, pre-OCT, try to give a scoring to it, and then in a very calculated manner, try to tackle this calcific lesion. Thank you very much for the patient here.
Thank you, Dr. Sao. Again, as usual, wonderful cases, wonderful demonstration, and the visual pleasure. Now, if I bring Dr. Rai first in this discussion, my question to you, what is your idea about the natural history of calcium in the coronary, human coronary, as far as its growth is concerned, its thickness, the arc, the length is concerned? It is always a downhill course of all the calcium. It is static, new calcium, old calcium. You have any idea of the natural history of the calcium, which is untreated or treated behind the stent?
I'm not very sure about what will be the answer to this, but definitely it is too early to say, because we have been using IVLs, we have been using this very recently in deep calcium. We do not know what will be the outcome, long-term outcome of this. These cases need to be followed up. When you push the calcium, dissect the calcium and push it against the endothelium, possibly it should work, but maybe we don't know, because we are delivering a lot of energy. We are sort of breaking the calcium, that the stent may again show problems.
So it's basically a theoretical question. Now, what I want to know, that if there is a space created by dissolution of calcium, breakage of the calcium, weakening of the titanic plate, do you think there will be a space created in the future, Dr. Rai and Dr. Javid?
Dr. Azra, I didn't get to your point.
Okay, so let me rephrase it. What is the natural history of calcium in the coronary, treated and untreated by a device?
In a treated device, the natural history is that the chance of a restenosis, if especially in, look, calciums usually prevent expansion of the stents difficult. So under expansion is quite a very, very high likelihood of under expansion unless you prepare the bed very well. And then you post dilate it very well and got a optimal results, especially if possible with the help of an imaging, you should get the optimal stent expansion. And otherwise, the natural history is rapid development of restenosis, especially in those regions where it is under expanded, and the event rates also quite high when compared to non-calcified vessels. So calcified vessels, what in the natural history of a treated lesion is chance of under expansion, chance of restenosis is high, and even a chance of stent thrombosis may remain high in those areas where it is malapposed or under expanded. In an untreated lesion, it may be a little interesting thing. This seems to be, these lesions seems to be quite stable. Unless a rupture at a calcified nodule occurs, they may not lead to acute coronary syndromes, unlike a soft plaque. That may be, I think, an important difference in the natural history of a treated and untreated calcified lesions. This is my understanding.
Dr. Rai, do you think it's a special phenotype, the calcified coronary artery disease is a special phenotype, or it is the same process of atherosclerosis? Unfortunately, some develop calcification, some do not develop calcification. The first question, is it a special phenotype? Is there a chance of calcium coming inside the stent, like a neointimal hyperplasia? If it is special phenotype, even the new atherosclerosis can get calcification. So do you have any idea that is a special phenotype? Whatever you put inside, there will be calcification in the future.
I think as of now, what I know that, whenever there is a rupture of the plaque, the rupture healing, this process continues. And in some of the cases, this healing process is associated with the calcification. We are yet to know whether there is a genetic predisposition or any special phenotype, but it is an extended process of the process of the basic atherosclerosis, where natural history, some of the ruptured segments get calcified. That's
Dr.
what
thank you. Dr. Kuntal and Dr. Mandal. First, Dr. Kuntal, the three cases you have seen, beautiful cases by Dr. Sahu. You have any comment and observation on his cases? First, Dr. Kuntal, then Dr. Mandal.
Sir, Dr. Shao is master of all these complex cases, so no comment. I have a very specific question rather. Nowadays, we are very much prepared for our calcified lesions. We have imaging, we have different tools, we have different debulking agent. But of late, what I find, it is very difficult to handle the fibrotic lesion. And very young patients, nowadays I am getting very fibrotic lesion in the mid-distal LAD. There is short availability or no availability of the adequate size of Wolverine balloon. Even sometimes we miss in imaging, and we are having some underdilated result or unexpanded stent, ultimately landed up with some residual stenosis after OP and NC. So how you people actually deal with this tight fibrotic lesion, which is not possible to actually guess in your angiography?
See, fibrotic lesions, if you have, the first thing is that most of the osteal lesions are usually fibrotic. That is one thing. Now, you gave me a subset where you are telling that it is a distal LAD which is fibrotic. Now, you'll see all LADs have got a natural history that gradually they taper down. So, you have to be very careful while using a Wolverine, very distal area LAD. That is one thing. And at the same time, we have to also think about the future of the patient. That is, we have to leave something for the surgeon. We just cannot go on implanting stents distally as possible. So one has to be a little bit careful in handling these cases. What I would suggest is that if it is a really very fibrotic lesion, use a cutting balloon. Then possibly, if required, now stents are available from 2 millimeter onwards. But please respect the surgeon and leave that some distal portion for the future. Don't screw up the life of the patient. And if it is not a very fibrotic lesion, if it can be seen, because distal LADs are very difficult to image also, because rather I can image better with an IVUS, not with an OCT, because OCT will be very difficult to cross totally distally and then see it. And then if you can just do a NC balloon and then possibly a drug-eluting balloon and leave it for the natural. This is what natural history. This is what I would do.
Dr. Mandal, your last comment on the case. First, out of all these parameters Dr. Anandraman and Dr. Sahu has mentioned, one is thickness, one is your arc, thin 360-degree arc, 7 or 8 millimeter thickness versus 30 millimeter long thin lesions versus calcified nodule. Out of all these four, which one is the worst animal in your practice?
Actually, I think that length and depth is very much important. So for natural history, what you asked, I think that the calcified lesion, they do not produce mainly SCS. And one of the important factor of calcification is that we are using high dose of statin. This may be one of the important factor that we are getting that so much calcified lesion now. And the calcified lesion, to me, that it is to some extent safe because it does not cause ACS unless and until there is calcified nodules. And I think the case that Dr. Sahu has shown us, this is excellent performance with, in fact, judicious use of OCT.
Thank you. So we'll move on to the last leg of our today's seminar, and we'll hand over the session to Dr. Kuntal for his beautiful lecture on FFR, RFR, help me to take top calls in my complex PCI. Now, Kuntal is our colleague. He's working in R.N. Tagore Hospital, Calcutta, and he's DM cardiology. He has a good pair of hands and thorough understanding of the complexity, and he has performed and produced beautiful results. He has presented many papers in local versions, other national versions and international versions. So welcome, Dr. Kuntal.
Thank you, sir, for your nice introduction. So my job is how FFR and RFR help me to take tough calls in my complex PCI cases.
Can you be a little louder? Can you be a little louder?
Yes, sir. So the definition of FFR we all know. It is the maximum achievable blood flow in stenotic coronary artery divided by maximum blood flow in the same artery without any stenosis. That is FFR is PD by PA with maximum hyperemia. So what is the clinical equivalence? So first you have to understand that we all know the mature operator. So it may be a recapitulation of the facts. An FFR of 0.9 equates to 90% of your normal maximal blood flow. So an FFR of 0.8 equates to 80% of your normal maximal blood flow. So by changing the FFR from 0.5 to 0.95 by stenting or by revascularization, the affected lesion, then you are increasing the blood flow from 50% to 95%. That is the basic understanding. So in any normal person without any stenosis, the FFR is 1. Similarly, any abnormal artery, the FFR should be less than 1. So the unique features of FFR is not influenced by changing hemodynamic conditions like heart rate, blood pressure, and contractility. FFR specifically relates the influence of the epicardial stenosis to the myocardial perfusion area and blood flow. So you should not confuse with CFR, which also incorporates the microvascular circulation. FFR accounts for collaterals, so very important contributors. And the FFR has a circumscribed threshold value of 0.80 as it is established in many studies, and it indicates your hemodynamic ischemia. FFR is easy to measure and the success rate is 99% with extreme reproducibility. Now coming to the RFR. It is one of the NHPR, that is non-hyperemic resting ratio, and FFR and RFR is actually a novel resting index that scans the entire cardiac cycle from systole to diastole, and it is the lowest subcycle PD by PA calculated as moving average. So it is a real-time data. So the best use of FFR or RFR is assessment of ischemia and stable coronary artery disease, ACS non-culprit lesion, during PCI or pre and post PTCA to assess the residual ischemia, then definitely in case of intermediate lesion, and whether you need a side branch intervention after doing a provisional stenting, and CABG. So coming to the real life history, real life thing. So if you want to use a hyperemic pressure ratio with use of adenosine, go ahead with FFR. But nowadays, most of the machines are incorporated resting pressure ratio, so you can go ahead with RFR. The cutoff for RFR is 0.89 and it is similar to IFR of Philips. Now the problem of FFR is when there is subsequent and closely related tandem lesion, you may get a false negative FFR for the proximal lesion. So in these cases, I will suggest to do RFR, where you can give a real-time value of the proximal lesion, irrespective of the severity of your distal lesion. Similarly, FFR is not very reliable in acute coronary syndrome because of dynamic nature of bed and lesion. So the scar compromises a significant amount, and the non-scar tissue, that is normal myocardium, is the blood flow is actually shared. So you may get a wrong FFR value. The outcome of post PCI is actually well established in several studies, and if we see the post PCI FFR, if it is more than 0.80, the target vessel revascularization rate is much more significantly less than the FFR value less than 0.8. Similarly, in case of RFR, the target vessel failure rate is higher when the RFR value is less than 0.9. This is the 1-year outcome of patient with residual physiological ischemia after PCI, that is defined PCI trial, and with IFR or RFR measurement, it has been shown in this study that 24% has residual ischemia following angiographic successful PTCA. And this is the outcome of all-cause death, MI, and clinically derived PVR. The rate is much more higher when the IFR values is less than 0.95. So the FFR is already established, and you know the recent FAME3 trial where the FFR guided triple vessel angioplasty is compared with CABG, which shows non-inferiority to CABG. But there are many problems with FFR measurement. You have to take care of drip, you have to take care of the adenosine dose while nursing staffs are preparing, poor pressure while handling, tandem lesions, microvascular disease, and recrossing stent at end of procedure. So these things can be easily taken care of by using nitrates at the initiation. Then normalize the pressure, check 0, don't touch while taking the measurement, watch the setup throughout, ask your assistant also not to touch anything, wait for the result, do not get hurry, do not jump, wait for the right time. This is the commonest error for FFR, that is drift. It is very commonly found, that easily can be taken care of. Then when the ostium is diseased, which may be ignored during your angiogram, may give a false result. So proper adenosine dose is advocated. So IV infusion is preferred over intracoronary infusion at the rate of 140 microgram per kg. And a large central vein should be prepared for IV infusion, not like a peripheral vein in dorsal part of the hand. And ask the patient not to take any deep breathing or doing Valsalva during the infusion. So the algorithm which is ideal in real life is any intermediate lesion, you measure the RFR. If RFR is less than 0.87, go ahead with your intervention. If it is in between 0.87 to 0.93, take a contrast FFR. If contrast FFR is 0.76 to 0.8, then you do a FFR assessment. So at that point of time, you only need a vasodilator. This is a case. I will show you only the static film, but you will understand. This is the crescendo angina patient, post PTC RCS 10 2 years ago, again came with angina. The LAD lesion and diagonal lesion all looking borderline. So what is your strategy? So one strategy could be one stent with provisional approach in the LAD, or you can go ahead with your multiple stenting, or you can protect your side branch with wires and do a provisional stenting. So we'll keep it as minimum according to the latest guideline and also EBC club. So it is provisional stenting with the wiring both the diagonals. So there are many options. I will go ahead with your provisional stenting, not a double decay crash or reverse crash or pull out, etc. So this is the procedure. Provisionally 3 into 28 millimeter stent was deployed in LAD. Good pot was done. Lower side branch was taken care of. Now this is the case after doing pot. So you can see both the diagonal has pinched. So this is the result of FFR. in both the branches. So final kissing balloon was done. I was not very much worried because there are two parallel and equal size diagonals, so one will take care of other. So drug-eluting balloon was not a choice. It is a good size vessel. Anybody can go ahead with double decay crush with 2 stents. So this is the final result, and this is the FFR. Now you can see there is a small dissection in the D2. It can be left alone because there is 2 parallel branch, and the upper branch shows FFR values of 0.82. So I left it. This is another case with LED stent with diagonal pinching, and this is showing RFR values of 0.96. So again, it is taken with only medical management for diagonal branch. If it is significantly less, then I will go ahead with drug-eluting balloon. Now coming to the gel branch after left main stenting, maybe it is left main to LCX crossover or left main to LED crossover. To 2 subsequent cases was shown. So after left main to LED stenting, you can see the LCX. So the LCX is looking a little bit smallish, and so this is the result in right hand side. The LCX FFR is 0.89, so it is not significant, so you can leave it. Somebody prefers to do OCT, and if there is any link sitting over the LCX ostium, you can reopen. It is your choice. I often don't prefer this technique. And this is another case with left main to LCX, but this is definitely stenting. This is actually bifurcation strategy. And the LED ostium showing a significant drop in FFR 0.70, so you have to tackle it. So to conclude, the FFR is the greatest body of supporting evidence, and it is considered the gold standard in the invasive detection of ischemia. RFR is a new NHPR, that is non-hyperemic pressure ratio, that assesses the hemodynamic significance of coronary stenosis, identifying the lowest distal arterial pressure and arterial pressure ratio over the entire cardiac cycle. So it doesn't require any hyperemia or any adenosine. Anytime you can repeat it during the procedure. The agreement between FFR and RFR is limited. However, the adoption of a hybrid RFR-FFR strategy, as I show in your flowchart, you can do whenever there is a gray zone. Then you should go ahead with your FFR assessment for final strategy. In intermediate lesion, bifurcation lesion for side branch, post-PCTA residual lesion assessment is prognostically best assessed by both RFR and FFR hybrid strategy. Thank you, sir.
Thank you, Kuntal. Dr. Devdatta, let me join back. Dr. Javid. So, if you bring the FM3 into discussion, what do you think? FM3, good trial, reasonably well done trial, or this trial doesn't say anything for 2021?
The trial is well designed, but the follow-up, when you're comparing a CABG with revascularization, the follow-up is only 1 year. So I think that is a major limitation. Previously, all trial where we compared CABG versus PTCA's older generation stent. So this is a study where new generation stent has been used. So I think, and the data was published before Excel. So that is actually tells us that this triple vessel disease, if we do FFR guided or RFR guided revascularization, then the outcome is almost same. Rather, the immediate post-operative complication and comorbidities, all these things can be avoided.
So if I come to Dr. Javid, what are the situations where you will never consider FFR, IFR? Are there any subset of lesions? For example, left main 50% on angiography, hazy looking lesions in the proximal LAD. What are the situations you will ignore even the good, ignore a negative FFR?
Ignore a negative FFR means a
like if you have 0.82 FFR or IFR 0.9 or 9.1, and you still want to go ahead with the stenting, what are the clinical scenarios where you defy the FFR or IFR negativity.
That especially in a left main, if it is a borderline FFR, there are limitations for the use of FFR in left main, and the data is also limited. So I will complement it with the use of an imaging, and that imaging, if especially IVUS, if the MLA is less than 4.5 and FFR or IFR is borderline, I'll go ahead with the revascularization. But in a non-left main vessel, especially LAD, I will rely more on FFR. And if there is a disparity between FFR and an RFR, for example, if the RFR is normal and FFR is low, there is no question, I will rely on FFR. But if the FFR is normal and RFR is abnormal, that is a situation where we have to look at the totality of the data, the clinical picture, the symptoms of the patient. Then here also I may complement it with doing an imaging. And always I'll think the final take or the final verdict will be by FFR rather than a non-hyperemic index. That is what my current concept.
So if I bring Dr. Sanjeev Rai into discussion, for example, one man has got 0.81 FFR in the proximal LAD. His IVUS shows that MLA is more than 4.8 or 5 millimeters square, but he has got NCLBI, which is around 550. The lipid content on lipidogram by need spectroscopy. Would you consider, in spite of having two negative things on physiology and in imaging, you still want to go ahead with the stenting? I think Sanjeev is Dr. Devdatta Bhattacharya. I can see you there, so I can pull your leg. You were sitting in a car. Okay. So what the question is, this FFR, IFR, everybody knows when to do, what not to do, what is the implication. The FAME3 trial, that it is not a great trial, I would say, but it does show that it's non-inferiority. The question is, when you have a proximal ostial LAD or left main, as Dr. Javid has mentioned, that even the FFR, there is a mismatch, and if you show that the IVUS is compromised MLA, this will go ahead. Now, I'm giving a theoretical or a hypothetical situation where FFR is 0.82, MLA is 4.9 millimeters square in Asian patients, and your lipid core or lipidogram on need spectroscopy, and I'm sure it will have, or in OCT, this is a high risk plaque, and the lipid content is more than, NCLBI is more than 550 units. Would you still go for a stenting or not?
See, if the patient has a presentation of ACS, then I will consider it. But if the patient is not ACS, then I would keep him on medical treatment.
Right. So that is a very important point Dr. Professor Bhattacharya has mentioned. If it is ACS, any one of these, if you think angiographically more than 50%, as Javid has mentioned, if the IVUS shows positivity, FFR shows positivity, FAME3 trial did include 5 days post-MI patient also. It's not that FAME3 trial did not take STEMI patient or non-STEMI patient. So if you think that there's a high-risk plaque on imaging, nasty plaque erosion, in ACS, you must stent it. Now, in non-ACS, a different ball game. Some people will stent it, some people may not stent it. But if you think it is supplying a large area of myocardium, medical therapy failure, you will have many trials to prove it, but it is not in the guideline. So if I come back to Dr. Kuntal Bhattacharya, that what should you do in the real life for triple vessel left main PCI? Would you send them for after FAME3 trial? If you like surgeon, they don't do FFR in all 3 vessels, but you do angioplasty depending on the FFR value. Now the MES is predominantly dominated by repeat revasculations. And repeat revasculation is a kind of contaminant, I would say. It's a spoiler for any trial which compares PCI versus CVG. For some people, even 2 PCI is much more preferable than one-time cut on the chest. So repeat revasculation for some people like RC, just 2 procedures. They may not opt for a repeat CVG. So what do you think? These MES should be restricted or analysis should be restricted to the hard points like death and stroke when MI definition is a controversial. So what is your take on phase 3 trial that this MACE should be separated, the softer MACE like repeat revascularization and MI should be separated from the death and stroke, these hard points. What's your take?
All these trials, when we compare CABG versus PTCA, if we not account this target vessel or repeat revascularization, then the hard point of MI and death, I think everything will be equal. Only the bleeding risk maybe in PTCA patient will be higher. But the trial design for primary outcome always includes MI, death, and TVR for all these CABG comparison. So design can be changed to.
So if I come to Dr. Javeed for the last comment of his expertise opinion, do you think the hard points and the softer points should not be clubbed or should be clubbed as usual? What's your take?
It should not be clubbed because we should look at the hard endpoints, especially the mortality. And I must add, a repeat revascularization is it's also an important endpoint because it's a one thing. That means the patient has symptoms. It could be an ACS. And the third thing is it involves the cost of therapy also. So it is not a soft endpoint, but the hardest endpoint is the mortality. And that is the definite endpoint. There is no dilution in that endpoint. So that is the best endpoint. And second best will be repeat revascularization. But repeat revascularization may not be a big problem. It may not be a big problem in countries where the insurance covers it, but it's a big problem for a country like India. So for us, it is quite important. For a Westerner, it may not be that important. With the advantages of the PCI, repeat revascularization does not negate the benefit of PCI.
So he has made a very excellent observation that cost-constrained or resource-constrained countries can go for surgery. For repeat revascularization will be costlier entity to the nation. But these points should not be clubbed, especially the definition of MI. How do you define MI is a controversial and contentious issue. Should go by death and stroke, which never can be in any trial, nobody can deny deaths. I mean, this has to be reported, and you cannot play with this number, the death number, but you can always play with the repeat revascularization, symptom, etc. So here, ladies and gentlemen, let me conclude here that for a particular patient, for an individualized patient, for individual complexity, you may have to apply strategy A, strategy B, strategy C, strategy D. Sometimes you have to combine. In a resource-constrained situation, you have to utilize your wisdom, your knowledge, your expertise. Look at the patient. So patient should always be there. And today's discussion, Dr. Devdatta Bhattacharya, my friends, Dr. Javi, Dr. Mondal, Dr. Kuntal, and other Dr. Rai has told us is the patient is one. You have to bring their mortality down, good quality of life, and at the end, the safety which can come with the help of imaging and modern gadgets, modern technology, this kind of conversation between friends. So I would conclude here. Thank you very much for joining us today. Sure, everybody has enjoyed. Over to the organizers.
Thank you.
Thank you.
Thank you, Doctor.